I'm here today with David Blumenthal, who is well known to the Carol Emmott community as the chairperson of our governing board for the Carol Emmott Foundation. Also an academic physician, healthcare policy expert who served, and this is germane for our conversation today, from 2009 to 2011 as the National Coordinator for Health Information Technology under the Obama administration. David has written a second book with James Morrone, who is professor of, let's see, what is it? He's political science and public
studies. Political science and urban studies
at Brown University. Their first book, The Heart of Power, Health and Politics in the Oval Office, looked at how presidents' personal experiences around health and loss shaped legislation and policy and their practices and affected the kind of healthcare approaches our government has taken through the years. And they've now written this book that I really enjoyed quite a lot, Whiplash, From the Battle for Obamacare to the War on Science. And I have to say, David, first of all, I mostly avoid policy books because the metaphor I've often used is it feels so often at the beginning like trying to move a mountain with a teaspoon. But you and James or your editors or someone makes you write quite briskly and very lively writing. So I think people, this is going to have an appeal, I think, to a wider audience, even those who don't consider themselves policy wonks. So let's start by giving you a chance to talk about what led you and James to articulate the connection between the battle for Obamacare and the rising antipathy towards science that we're experiencing everywhere.
Yeah, well, we didn't plan that. We started this book and planned the book and got a contract for the book before the pandemic. And we were going to roll right along with the Affordable Care Act and cost control and all those traditional healthcare issues. And then a funny thing happened on the way to publishing this book. So the more we got into the pandemic and its consequences for all the things we're seeing now, trust in science, trust in public health, trust in vaccines, the more important it seemed, and the more whiplash-like it seemed that our battles over healthcare veered away from everything we've been fighting with about for 100 years into this new terrain of fighting about the culture of health and whether health care experts are a tyrannical elite. And that struck us as a discontinuous change in American healthcare. And so that's partly where Whiplash came from. It also came from the contrast between the presidents we've had. So you start with this charismatic, Black, intellectual, wonderful orator, symbol of American diversity. And then he's followed by someone very different, to put it diplomatically, someone who doesn't tolerate diversity, someone who's against diversity, equity, and inclusion, someone who's an economic populist, who's anti-elitist, even though he's a member of the elite, and whose style is not at all intellectual. It's all his speech is very basic. I could go on. And then he's followed by Joe Biden, who even before his health deteriorated, was kind of a government technician. His successes came from his intimate knowledge of the levers of government. And that couldn't have been further from President Trump. So anyway, we thought that was another whiplash-like metaphor, the changing nature of our leaders.
Well, and it also illustrates the power of kind of reframing your arc in a book like this. It not only changes a lot of the information you share, but it also gives a different perspective when you have this longer frame, I think.
Hmm. I hope so. But it was, for me, as a physician who knows infectious illness as a primary care physician, but not as an epidemiologist, not as an expert on pandemics, to have to delve into the pandemic phenomenon in the middle of this was really eye-opening. And now I teach a course on presidents and pandemics because I have found it so illuminating and important. But we can go into that as time and your questions.
Yeah, that's really valuable. I think that's really important. I think just to talk a little bit about the book itself. One of the things I appreciated, which we don't always get, is you kind of like my math teacher always expected me to show my work, and your notes are copious. That's of course understood. References, I expected all of that. But what I didn't expect were the appendices, where you actually did some of the preliminary studies, obviously, that you did that led into the book. And I found that kind of digging into some of the deeper background to be particularly useful. What made you decide to incorporate all that?
Well, we were very much aware of the moving mountains with a teaspoon problem. We wanted people to want to read the book, and we didn't want to do a lot of detours into deep nerdiness with the history of the healthcare coverage issue. And so we wanted to make the book move quickly, and for that reason we added appendices where we thought it would be helpful to readers if they were so inclined, but
Right.
not to disturb the flow of the book.
Yeah, that makes a lot of sense. Well, as you probably have guessed, I'm one of those strange, let's just go ahead and say odd people who read footnotes, references, and all the accompanying material. It's just frightening.
Hats off to you.
Well, I don't know. I don't consider it a virtue, but rather a disability. I'm one of the, I think, most powerful analyses that you provided of the American healthcare system lies in your view of the values differences, the opposing views of Democratic and Republican lawmakers. And I know that James has written actually quite a lot about the kind of the moral basis of political life. So it was not surprising that this was a part of what you were doing. But you say in the book that the opposing views of these two parties, quote, rested on profoundly different moral principles. Would you talk a little bit about the values conflict that drives the division in our country?
Sure. And here I have to credit my co-author, Jim Morrone, who is a political historian, but as much an historian of American thought as he is of the political events of our country. So he is the one who really emphasized that, though I have long thought about it and conceptualized it. But this has a lot to do with the difference between libertarianism and communitarianism. The extent to which, like Europeans, we view ourselves as a single community and make solidarity an underlying shared value, which is essential to the risk sharing that you have with a universal healthcare coverage system, in which the sick are subsidized by the wealthy and the poor are subsidized by the healthy, and the poor are subsidized by the wealthy. In Europe, that's not questioned. In the United States, there is a large component of our country who believes that that's not morally correct, that people should keep what they've earned and go beyond that. And this is something that troubles me as a physician. to blame illness on the individuals who fall prey to it. And we all know in our families, and here I will divert into my clinician role, we all know in our families that people get sick through no fault of their own. They have car accidents when they're not driving drunk. They are injured by others through no fault of their own. And they, not only that, but they get cancers that are not caused by smoking or overeating, or obesity or poor nutrition. Bad things happen to humans. So the idea that you should bear the costs of illness because they are somehow your responsibility is not consistent with any real attributable responsibility that I see as a practicing physician. So
Right.
I find that position certainly morally different. It's a different view of humans and what they're accountable for. And one that I find hard to believe that physicians would embrace for the most part, but some do.
Yeah. Go ahead. Were you going to say more about that?
No.
Well, I mean, this is a thread that runs through American life. I, as a former pastor myself, I'm really familiar with the kind of success gospel, the Norman Vincent Peale approach, and we see this in many very popular preachers today. Do you think I'm too cynical in reading in a high level of cynicism into the position of one side of this, the side of the elites? Because I say on the face of it, the simplest explanation is that the elites believe they have no need for public health because they are insulated by wealth and access to resources that the population doesn't have. And and this is the part where my own cynicism comes out. It seems to me that at least one driver is that addressing larger population needs has negligible financial benefit to them, whereas the kind of focus we have on security, armaments, this kind of thing, where there are really clear financial benefits to a whole lot of folks that have power and influence in the country. It seems. I know I'm oversimplifying, but I yield to my own cynicism sometimes on that.
Yeah. Well, this exceeds my brief as a scholar. So
thank you. I don't want to create too much trouble before you even get this published.
I have worked my entire. First of all, let me start by saying, my father fled Germany in 1935 after he was kicked out of high school. And though he was an exceedingly intelligent man and ended up being highly educated, self-educated, he never finished high school, he never went to college. And he understood the danger of a self-interested and non-communal view of society. So I think, and he was a great champion of human rights. So I think my brother and I were both inculcated with a sense of social responsibility that was based on historical experience. So I find it very hard to identify with the self-interested perspective that I see when people arrange their lives around their financial benefit and try to avoid any responsibility that they can for others. Any tax loophole that is legal or even one that isn't is just fine. I find that incompatible with my own principles and viewpoints. At the same time, it's profoundly human. We scrabbled our way out of the African savannah not by being communistic, but by protecting ourselves and our families and forming clans and fighting constantly for our territory and our hunting grounds. And so I think it's the idea that we share the world and welfare with others may not be a fundamentally human attitude. I do think in the area of pandemic, this is particularly telling because the idea that vaccination is not just a personal benefit, but a societal benefit is something that has been very hard to communicate recently to people. That is, you vaccinate yourself to protect others, not just to protect yourself. And this comes around a little bit with the controversy around schools and their closure in the pandemic, because it turns out children were not deeply affected by COVID, but they could transmit it. And they shared it among themselves and then took it home to their families. So the closure of those schools was not just about the individuals, the children, it was about everyone else who had contact with them. And that required you seeing the world as an entire community, not just as a aggregation of individuals. There's another way of seeing this, another moral division, and that is and this is again Jim's influence. What is freedom? So there's FDR's view of freedom, which is freedom from want. That to be a free person, you have to be secure in your home, secure in your nutrition, secure in freedom from illness or the cost of illness. And then the other side is freedom too. I'm free to do whatever's legal, regardless of the consequences for other people.
Mm-hmm.
And the perfect analogy is, where does your freedom end when you're swinging your arms? Does it end at the nose of somebody else, or does it keep going? And so those are kind of, I think, underlying the division between, in some respects, the parties. One
Right.
emphasizing freedom from and the other freedom to.
Yeah, nice framing. I think one of the most powerful threads running through your book is this identification of both hidden and explicit incentives for behavior, and it fits with what you're saying. I think, in terms of protection of my own family, and there are certainly incentives to behave and to think in certain ways. And fairly early in the book, as you were looking at the American insurance system, there was one rather provocative statement, I think, that addressed the question of incentives built into our systems. The phrase in the book is "seek the healthy, shun the sick," is the principle that operates the American insurance system. Do you want to say a little bit about that?
So it unregulated, the self-interest of for-profit insurers will drive them to try to make sure that the amount that they collect in premiums is more than they have to pay out in costs. And that falls to their bottom line, and it enables them to go to their shareholders and say, we're protecting the value of your shares. And hopefully that profit gets bigger and bigger every year, and Wall Street analysts see growth, and you get a multiple of your earnings in the price of your stock, and away we go. But if you have a lot of sick people in your risk pool, that goes to what euphemistically we call the medical loss ratio, which is like the amount you actually pay for coverage, for care. So that turn of phrase is such a distortion of what's going on, because the losses are not losses, they are payments that are the purpose of the insurance, payments for care of people who presumably need it. It's not a loss by that standard, it's a gain. People are gaining, but the shareholders are losing. So the idea is to minimize the medical loss ratio, that is to cut down on the amount spent on care. Well, if you've got a lot of people with cancer, diabetes, heart disease, cerebral vascular disease, behavioral health problems, you're going to have problems with your medical loss ratio. So how do you minimize your medical loss ratio? You don't insure those people if you can avoid it. And the result is that unregulated insurers will screen people for pre-existing conditions and for risk. And if you're in my generation, you have had that experience, whether it's in life insurance or health insurance, that a nurse will come to your home, take your blood pressure, take a history, and your premiums will be reflected in the risk profile. It's called underwriting. And if you underwrite health insurance, there are a lot of people who are sort of tossed overboard.
You drew attention, though, to some of the unexpected impact of regulation. I'm thinking about the marketplaces and its impact on the health insurance agency, that in fact that certain kinds of structures that came out of Obamacare were actually beneficial, along with a lot of regulations like questions about prior conditions, this kind of thing. Can you say a little bit about how that operated?
Well, what President Obama did, to the dismay of the progressive wing of the Democratic Party, as represented by Bernie Sanders, is he accepted what to me was the reality that the federal government was not going to destroy our insurance industry. That it is that our government has never been allowed to take an industry and say, you're done. We're taking over your industry. And you built it from scratch. You've got all these shareholders. Tough luck. You're out of business. And that's what Medicare for All would do for all to advantages. Not going to happen here. So the question was how to make this private insurance market that we just described work. Well, fortunately, there are examples in other countries like the Netherlands and Germany where regulated private insurance works quite well. But you have to set boundaries, you have to set guardrails. So this underwriting that I described can't be permitted if you want to cover people who are very sick. You have to force insurers to include them in the risk pool. And that's the purpose of insurance. When I was younger, I insured people like what I am right now, which is an older person with health conditions. And I didn't realize that I was paying a higher premium than I needed to, but I was. I never used a doctor in my 20s, 30s. Now I do. And there are lots of 20-year-olds that are paying for me right now. Actually, it's Medicare, so it's lots of working people. So that's the principle, and that's what the Affordable Care Act required of insurers by regulation. In other words, you couldn't sell insurance in the marketplaces unless you did away with underwriting, except for certain particular categories having to do with age, especially. And then the differential in the prices you could charge because of those risk factors was limited by statute. It also did something else, which is it tried to simplify the nature of the products so that people could make more intelligent decisions. Buying insurance is a confounding thing for, I think Albert Einstein would have pulled what little hair he had left out, trying to figure out what the best insurer was for him in the United States now. So much complexity, so many moving parts, so much unpredictability. So what regulating, when it works, what regulating does is it says we're going to get rid of this competing on risk, competing on hidden costs and hidden limits on coverage, competing on dropping people when they get sick. So sure, we'll stop underwriting, but we'll limit what we'll pay for you to $5,000 a year. And as soon as you hit that, you're out of it. So limiting those things that make insurance no longer work as insurance. And that's basically what the Affordable Care Act did. It said, private insurance, we welcome you as the solution to covering more Americans, getting to universal coverage. You just have to play by certain rules. And actually, I think the insurers ended up buying that because it led to a lot more business, and maybe they wouldn't make as much at the margin, but they'd make more than they would have, because otherwise those people wouldn't have had insurance at all.
Right. One of the things that you pointed to that I thought was particularly connected to our work with the Carol Emmott was that you were talking about the two women, Nancy Ann DeParle and Jean Lambrew, who ran the implementation of Obamacare from the White House. And we quote them as saying, here it is, the ACA succeeded from passage to implementation because women led the effort every step of the way. You want to say something about that?
Well, actually, there was a third woman heavily involved, and she worked for the Senate Finance Committee, and her name was Liz Fowler.
Okay.
Good friend and colleague of mine. So, yeah, it was women all the way. And Nancy Ann and Jean were the key. Nancy Ann was a key advisor to the president during the effort to pass the legislation. And she then moved up in the hierarchy of the White House to being Deputy White House Chief of Staff. And when she did that, Jean, who is a absolutely spectacular expert on everything in health policy and an indefatigable worker, took over on the front line of implementation. And Nancy Ann continued to be involved, but she also had to be involved in, labor issues and tax issues and all kinds of things. But Jean picked up her portfolio. So it was absolutely, as you looked at the people who were whispering in the president's ear or whispering in Max Baucus's ear, they were women.
Yeah. What did they do that might have been different from what we'd seen in other situations that reflected their approach that would lead, them to, we're not saying women are better than men, period. We're saying that these women did some things differently than we've seen in some of the male-dominated implementation efforts. What did you see?
Well, we didn't do a controlled trial here.
Right. Okay. So there's no control. Okay.
Unique time, and it so happened that women had earned the respect and opportunity of these powerful men to run these policy creation and policy implementation tasks. They were both deeply knowledgeable. All three were deeply knowledgeable, Liz, Jean, and Nancy Ann. Nancy Ann had been head of CMS. Jean had been a White House aide to Clinton during the health reform effort in the Clinton time. And she had continued to work on healthcare policy. Nancy Ann had continued to work on healthcare, but more in the private sector. So there was no need for them to do a lot of on-the-job training. They knew these issues backwards and forwards. Now, you might say that one of the reasons that women are so effective is because they are never handed these roles unless they really earned them. And they did not have to have on-the-job training. Their skill was not politics or general economics. Their skill was deep knowledge of the healthcare system from work they've done before. So that may be one factor, that they really had to have earned the roles that they were allocated. I think another factor is that Nancy Ann and Liz particularly are, they're very good at relating to people. And they're both very smart and very personable. Jean is very personable too, but Jean has a driving, they're all three highly driven people, but Jean was forced by the implementation challenges, which were huge, and which we discuss in the book, to be, I think, a little more of a taskmaster than Nancy Ann or Liz had to be.
Mm-hmm. Mm-hmm.
But all three of them are remarkable women, and I think it's a natural evolution of healthcare as a field that women are coming to play a more and more important role at every level, because it is a field now dominated by women. And it's naturally become true in government, in most normal administrations.
Yeah. And I have some thoughts about that because I've examined this for a long time, and you and I can chat about that another time. In the meantime, I have another question. I want to think about the future, about where you think this can go. I was struck by, in the book, you mention in the country's entire history, just over 1.3 million Americans died in war. And at the time you were writing this originally, or your statistics, you had COVID had killed 1.1 million. I think most people agree it's like about 1.22 million in under 4 years. And it continues with long COVID. My youngest brother died basically of complications of long COVID as well.
Mm.
What's it going to take, I guess, is the question I have. Will it take another pandemic? Would that be enough to make the case that you've made, I think, quite clearly that we are grossly unprepared for the future of healthcare in the country, for the dangers that we face as a world, certainly as a country as well? What's it going to take, is in your opinion?
I wish I knew exactly. One thing I'm sure it will take is a president who understands this and is committed to making it an issue and to preparing the country. Interestingly, there are two presidents who have emphasized this. One is George W. Bush, post 9/11, and he was prompted by the bioterrorism threat. But he also read The Great Influenza, the book by John Barry, and I think he got religion over that. So he did quite a lot to stand up a pandemic capability. And the other was Barack Obama, who in the first year of his presidency had to deal with another pandemic, H1N1, which fortunately was not deadly, but it was widespread. And the other was Ebola. And he came to the conclusion that he was not prepared to deal with infectious threats, and he set up a division of the National Security Council, which Trump later disbanded in Biosecurity Directorate in the National Security Council. So and also created some plans. So I think another pandemic may be required, but we'll also need to have a president who has the temperament, judgment, and courage to teach the nation what is required to protect us and to take the actions that are required. Congress has to be on board for it. We are now in a situation where pandemic has become a four-letter word for a large portion of the American public. They don't want to remember it, or they don't believe it ever happened. And it is a polarizing word in the Congress, among states, and frankly, we are less prepared to deal with pandemics now than we were when Donald Trump came into office. And the reason is that we are taking apart elements of the, if you will, the walls, the fortress that we could be making. We are unilaterally disarming against pandemics. We are not funding the development of new vaccines that could be multi-dimensional in their ability to protect people against infection. We are not funding public health at the local level. We are not planning for pandemics. The book has, I think, explains why this is happening. It's quite, it reflects the personal stakes of the president who was in office during the pandemic, the first president, and the conclusions that he came to about what was happening. So I have to believe that humans have the ability to make wise choices collectively, but it may take another catastrophe or multiple catastrophes. I might have concluded that this pandemic would change our politics with regard to government's role in protecting health. And it did exactly the opposite. It needn't have done that, but it did. And we are living with that legacy. The thing that I came to understand as I delved into the pandemic issue was that it is not a health issue, it's a national security issue. And it needs to be framed that way. And one way of framing it, the reason why we emphasize the casualty figures, is that we expend trillions of dollars to prevent terrorist attacks which regrettably kill 50, 100, 1,000 people at their worst, and which don't fundamentally alter our society. 9/11, for whatever, as awful as it was, had nowhere near the effects on us as a people as the pandemic did, in terms of political polarization, in terms of economic consequences, in terms of consequences for the education of our children, in terms of our international relations, nowhere near that. And yet we have been working so hard to prevent another 9/11 when we are basically completely avoiding the idea of another pandemic. Now, I want to add something that came to me. So I have a good friend, a woman, who's a poet, longtime friend. And as I was telling her about this book as we were writing it, she said, "Are you aware of the literature about pandemics?" And I said, "No, I haven't thought about that." So she said, "Well, there's a whole literature about pandemics, 1918 flu especially. You should look at it." So as we began to go into it, we realized that mostly it's written by women. 1918, men were writing about the war, women were writing about the pandemic. Why was that? Because illness is a women's issue in our society. It's what is the classic Western story? John Wayne goes out, he gets shot in the arm. Some attentive female takes care of him, and then he goes off again to fight the bad guys.
Right.
And that is the woman as nurse and the man as warrior. That is the classic prototype. Well, that's how our military and intelligence services cast themselves. And that's how a dominantly male ethos has us structured. We have these huge aircraft carriers in the Middle East bombing the hell out of Iran. And we're not doing anything about a possible pandemic. So I think there's a kind of underlying this agenda issue as well, that brings us back to the Carol Emmott Foundation.
Well, thank you, David. This book, I think, is one of the strongest statements, and I hope a lot of people read it, because I think, in fact, it's one of the nudges that may get us to take more seriously that public health is not a private issue, that health is not a private or individual issue. It affects all of us, and that disease does not stop at your door because you have a lot of big walls. So I'm hopeful for the impact of this, and I'm looking forward to seeing it published and seeing what people have to say about it. But thank you for spending this time with me. Also express our appreciation to your colleague, James Morrone. And that concludes our time together today. Thank you.
Thank you, Doug. Enjoy it.